I think we can go ahead and get going. So again, good morning, everyone. Welcome to our launch of the Brain Health Community Collaborative Echo series. We're so excited to have you here with us today. We believe this program is more than a simple learning opportunity, but really a space for connection, collaboration, research, and shared discovery that we can embark on together. So, the conversations today, again, are going to shape, we believe, the brain health of Texans 30 years from now, helping us build a foundation for healthier aging across our communities. Through this collaborative effort, our aim really is to strengthen partnerships between research and community leaders, um, translate cutting edge science into practical strategies that improve lives today, and open doors for competitive funding and research tomorrow. So today, we're going to begin our conversation by discussing the healthy aging and research funding landscapes for dementia and related diseases. So to start off, I just wanted to take a step back to share with you that our team really made an effort to consider who's in the room today as we're starting these collaborative partnership conversations. We're seeing more than a list of just names on our registration list, which included over 200 folks right off the jump, which is really exciting for, I think, speaking to the conversation and buzz around this topic and the leverage that we can use to move our conversations forward. So we started to try to understand this snapshot of the Texas healthy aging and brain health ecosystems. So where this high-level analysis, just coming again from the brief information we found from our registration list, was used to understand the organizational landscape we're representing in our conversations today. And what really emerged is a diverse network of academic researchers, clinicians, community-based organizations. We have public health agencies, nonprofit leaders, aging service providers, policy and advocacy partners, and more. Telling us something important, right? So, brain health is not owned by one sector, and it's not just one conversation we can have in a research journal, right? It's shaped by these interconnected systems that are delivering healthcare and community resources and attending to the social determinants of health and research institutions and funding structures across our state. And many of those systems are represented today in this room. And with that, I would like to turn our conversation over to Melissa Sanchez, who is representing the Alzheimer's Association as the Director of Public Policy, and is speaking with us this afternoon about her work for dementia research, prevention, and collaboration in Texas. Thank you, Melissa, if you'll get us started.
Thank you, Lauren. Good afternoon. I'm excited to be with you all today and to be a part of this important ECHO conversation. Just want to start off by saying when I talk about dementia today, I'm really talking about one part of a much larger brain health conversation. And that's one that spans prevention, mental health, aging, chronic disease, and the systems that support people across the lifespan. Dementia may not be the entirety of the brain health conversation, but I think it is one of the clearest signals of where our systems have succeeded and where we're falling short. These numbers on the slide in front of you are from the Alzheimer's Association's Alzheimer's Disease Facts and Figures report, which provides an in-depth look at the latest statistics on Alzheimer's disease prevalence, mortality, caregiving, and cost of care. In our communities, Alzheimer's and dementia have affected many of us, but worldwide, the numbers are staggering, as you can see. There are over 7 million Americans living with Alzheimer's today, but the impact goes beyond those living with the disease. There are nearly 12 million people caring for people with Alzheimer's and dementia, who would provide more than 19 billion hours of unpaid care at a value of nearly $413 billion. But I want to highlight a bright spot for you all in the middle of all this, for something for you to keep in mind, and that's that 4 in 5 Americans feel optimistic about new treatments in the next decade. And as many of you already know, there are lots of reasons for that hope. Next slide, please. And here in Texas, the numbers are also immediate and urgent. Today, 460,000 Texans are living with Alzheimer's. And without bold action, that number is expected to rise by over 20% just in the next 5 years. Millions of family members are providing unpaid care, often while working, raising families, and managing their own health issues. The numbers are overwhelming because behind every statistic is a real person, a real family, and a real story. Next slide, sir. Our vision at the Alzheimer's Association is a world without Alzheimer's and all other dementia, because together we can change the future. And I want to emphasize that word together because we're going to talk a lot about togetherness today. And what makes this moment different is that now we have scientific progress. We have policy momentum and growing awareness. And we're at a critical juncture in Texas with the recent approval of the Dementia Prevention Research Institute of Texas. But make no mistake, progress will stall without intentional collaboration across sectors. And so I want to, finishing with my slides, but I want to start the conversation by just saying thank you, truly. Whether you're working in a research lab, you're seeing patients in clinics, you're designing health plans or supporting families in the community, dementia shows up in every one of your worlds. There's no one in the Zoom room who isn't touched by it in some way. And that's because dementia care and prevention don't live just in one lane. They sit at the intersection of research, of clinical care, of payers, and community organizations, which also means something really important, that no single sector or part of the government can solve this on its own. Researchers, you're making real discoveries, but without real-world implementation, sites across Texas, those discoveries don't always translate into day-to-day care. Clinicians want to deliver evidence-based dementia care, but many are doing it without enough time, training, or reimbursement to make it sustainable. Insurers care deeply about outcomes and long-term care costs, but too often, dementia is still treated reactively after a crisis instead of proactively. And community-based organizations on here are really who families trust the most, are providing critical support every day, but are rarely resourced or included as true partners in research or care models. So yes, everyone here plays a critical role and collaboration is essential. But I want to take a little bit of a step back and just talk about our state and Texas for a minute, because Texas is both uniquely positioned, but we're also uniquely challenged. We're a big state. We're incredibly diverse, and we're aging fast, faster than the national average. But we have world-class academic medical centers. We have strong life sciences and biotech capacity. We have large booming cities, but we have vast rural regions. And we have racial, ethnic, and socioeconomic disparities that shape real health outcomes. So we're at a crossroads. We can become a national leader in inclusive, scalable brain health and dementia research and care, or we can fall further behind as demand overwhelms systems that aren't built to work together. From the perspective of the Alzheimer's Association, Texas isn't starting from scratch. There's amazing and great work happening already in our state. But we do have to be intentional about something, and that's building bridges and not more silos. We've seen meaningful scientific progress in Alzheimer's and dementia research, and that progress brings hope. But the next phase of impact requires us to expand how we truly think about research. We need research that spans prevention across the lifespan, early detection and diagnosis, care delivery models that work in real clinics, and science that tells us what actually works in Texas communities. And that is where collaboration becomes transformational. Because from our perspective, research that never reaches families is unfinished work. So what does success actually look like? Well, from where we sit, it looks like researchers bringing clinicians, payers, and community partners to the table from day one, not at the end. It's health systems embedding dementia best practices as standard care, not treating them as short-term pilot projects. It ensures aligning reimbursement with evidence-based dementia care. And it's community organizations being resourced as long-term partners and not afterthoughts. But it's also that shared accountability. So ensuring that we're sharing data, that we're sharing learnings, shared outcomes, because brain health is too complex, it's too costly, and it's too personal for any one of us to try to solve it alone. We have the talent in the state. Texas has the scale, and we absolutely have the urgency. And the Alzheimer's Association is ready to partner with researchers, clinicians, insurers, and community organizations to turn progress in brain health into real lasting impact for Texans and their families. And the real question I leave before you is whether we're willing to meet this moment together. And that's why I want to finish off with just, explaining why the creation of the Dementia Prevention and Research Institute of Texas represents such a prime opportunity for the state. But to help ground us with what that opportunity could look like in practice, I'm excited to turn it over to Cancer Prevention and Research Institute of Texas's Chief Scientific Officer to share what stakeholders can realistically expect for DPRIT based on CPRIT's experience building a nationally recognized research and collaboration system. Thank you very much.
Thank you, Melissa. Sorry, searching for my unmute button. As Melissa mentioned, I'm going to turn the conversation now over to Dr. Scott Hebert, who is the Chief Scientific Officer of the Cancer Prevention and Research Initiative of Texas, who's going to talk to us about some lessons learned and his experiences working with CPRIT's program and some preliminary ways we might expect DPRIT to parallel some of CPRIT's program structure. Thank you, Dr. Hebert.
Thank you so much. Appreciate the opportunity to come and tell you a little bit about CPRIT and try and draw some parallels to what we expect for the Dementia Prevention and Research Institute of Texas as it launches. So CPRIT's mission began in 2007 when Texans voted to establish CPRIT with a $3 billion bond, essentially. So the way CPRIT works is that every year we issue $300 million worth of bonds. And so we have $300 million a year over 10 years to spend. In 2019, CPRIT was reaffirmed and extended for another 10 years. So by the end of 2029, we will have spent about $6 billion, increasing the ability of Texas to carry out research and I think really doing some fantastic work. And we actually have three different buckets that we really sort of as metrics, but I think the critical one is we want to make sure that we're pushing the science out to people in Texas. Now, just to give you an idea of what cancer's impact is on Texas, about 150,000 Texans will be diagnosed with cancer each year. And so the economic cost of that burden is dramatic. And of course, this year we hit a milestone in which 70% of cancer patients actually are expected to live for up to 5 years with their cancer, which is a fantastic milestone to hit. But it does mean that the economic costs actually do continue because we have to continue treating people, and these medications are super expensive. Now, for Alzheimer's, we do have one or two medications that are approved, which is fantastic, but obviously we have a lot of work to do. Now, in terms of how we spend that money, which I think is really the crux of what you'd like to hear today, sort of how DPRIT might be spending their money. DPRIT was modeled after CPRIT. It's almost like a find and replace for the CPRIT in the statute. So this is probably the model. I should say that this was a model developed by the initial CEO and chief scientific officer, and it's been carried forward since then. And I think it's worked incredibly well. And so we're hopeful that DPRIT will take the same model. I should also point out that we're in the process of doing some revamping. We've got a new grants management platform that's going to incorporate a lot of artificial intelligence activities in it. So we're also hopeful that DPRIT will take that and sort of will give them an entirely new grants management platform that should save them a ton of money and make them more efficient. So up until about this time, well, about 6 months ago, we had actually given out over just under $3 or $4 billion worth of grants. We're now over $4 billion worth of grants, so it's really fantastic. We actually have three different big buckets. So we have academic research, which I oversee primarily. We have prevention work, which Ruth Rikus oversees. She's our chief of prevention. And then we actually have product development, which Ken Smith is overseeing for us right now. He's the chief product development officer. So this is a little unusual. So academic research, I think everybody at the university kind of understands what that is, although I'll break it down for you. There's probably some surprises that you maybe haven't thought about. Prevention is actually prevention services. It's not research. We're actually going out trying to find cancers, teach people of how to do sort of cancer screening, but it's early detection. We spend about $28 million a year on prevention. That is fantastic money spent, because for every cancer detected at an early stage that can be simply cut out, we can save the state millions of dollars in chemotherapy and targeted therapy and immunotherapy costs. So that's a fantastic component of what CPRIT does. In terms of product development, we spend about $75 million a year on companies. So actually, it's not economic development. This is what we call non-dilutive funding. That is, we provide the funding to these companies to develop a product. And in some cases, we're paying them actually to relocate to Texas and do their actually research and development clinical trials here in Texas. It's really a unique aspect of what CPRIT does. And I think that this would be really cool for DPRIT to do as well. Now, in terms of academic research, we actually have multiple buckets there. We actually do I think one of the most impactful things we've done is actually recruit new faculty to Texas. So we give recruitment awards, and the way that works is the institution, actually, after they've identified a recruit that they'd like to bring in, will apply to CPRIT. If the application is funded, and it's very competitive, they'll be then given basically a recruitment package to bring that person to Texas. Has to be from outside of Texas. But those are very robust packages. We offer $2 million for first-time faculty, $3 million for sort of intermediate faculty, sort of associate professor level, and $4 million for senior faculty. So, and I should point out that for all of our grants, the institution has to do a 50% match. So if we give an institution $4 million, the institution has to match that with $2 million. So it's a total of a $6 million package, at least a $6 million package. So these are really robust, and these give you the ability to really bring in some fantastic scientists. And among those that we've brought in through this mechanism are multiple National Academy members and at least one Nobel laureate, Jim Allison at MD Anderson. So really fantastic. On top of that, we actually fund core facilities and research training awards. So we fund PhD students and postdoctoral fellows to work in Texas. So building up that workforce and really growing the entire academic process. So far, in terms of academic research, we've given out just under $3 billion of grants to our institutions. this has led to many different discoveries. In this area, we do actually fund research in prevention and early detection. Obviously, therapeutics, very interested in translation, but also we really, I think, have done a fantastic job of increasing the sort of national and international view of Texas as a research destination by bringing in many fantastic investigators. I might highlight that we do have a little bit of an unusual mechanism. We call these TREC grants, or Texas Regional Excellence in Cancer grants. These are center grants that are specifically targeted to institutions outside of Dallas and Houston. So we do want to take this research and get all of Texas involved. So we're especially interested in funding non-Dallas, non-Houston sites. So I think that's an important thing to keep in mind as you go forward. Now, that's all I had prepared, but I do want to leave you with a couple of just ideas about DPRIT or issues. So as many of you might know, and probably many don't know, DPRIT has yet to be launched. And that's due to a lawsuit that was filed, I think, in Austin. And until that lawsuit gets resolved, there won't be any movement. So unfortunately, there's not much going on. But what has to happen initially is that the governor, the lieutenant governor, and the Speaker of the House have to appoint a board of the oversight board. Each has three nominees. That board has to be then formed to hire a CEO. And then once that's done, then the board will focus on hiring the chief scientific officer. And at that point, things will start moving and the administrative structure will be built out. But I just want to emphasize that we're here to help, and we will help them get launched as soon as possible. I think we have all of the policies and procedures in place that weren't developed in 2007. And so we can actually get DPRIT to be launched very, very quickly. And they may not even have a peer review structure. I want to emphasize our peer reviewers are all from outside of Texas. So there's no conflicts of interest where everything we do, but everything we do gets a rigorous peer review. And so we really rely on that. So they'll have to set up all those structures, but in the meantime, we can help them. For instance, with the recruitments, you need fewer reviewers to review the recruitment awards. So there's a lot of things that they could launch quickly and really start to have impact really within just a few months. So hopefully the new CEO will come to us and want to use our systems, and we're ready and willing to help. With that, I'll stop and I guess we're going to take questions at the end, I think.
Yep, we're going to reserve questions for the end. And if anybody has any thoughts, it's a great opportunity to remind you to place any comments or questions in the chat as we're moving through, and we will try to make room for that group discussion in just a moment here. With that, thank you so much for sharing all of that information with us and helping really tease out some of those parallels between the two structures. That's really helpful. Now we're going to hear from Alida Coutinho, who is the Aging Services Council and Aging Disability Resource Center Network Coordinator for the Capital Area Council of Governments here in Texas. Alida is going to talk to us a little bit today about the role of healthy aging organizations in research initiatives and fit with community experiences. So I will now turn it over to Alida. Thanks so much.
Good afternoon, everyone. My name is Alida Coutinho, and I serve as the Network Coordinator for the Aging Services Council and the Aging and Disability Research Center at the Area Agents and Aging Capital Area. And my role sits at the intersection of regional coordination, direct services navigation, and cross-sector collaboration across the 10-county region in Central Texas. And while I'm not a researcher, myself, I operate in a space where community voices, services systems, and implementation realities meet. And that is a space that is critical for translational research. In my role, I work closely with older adults, caregivers, nonprofits, government agencies, health systems, and private sector partners. And through the Aging Services Council, we convene these partners to regularly meet and discuss about services gaps, program updates, and emerging trends and regional priorities, which often allow us to see patterns before they even before they even make it to the data sets. We hear about caregiver burnouts during outreach events. We see behavioral health waitlists increasing through referrals navigation systems, and we observe transportation barriers affecting access to memory assessments or other mental health related services. We hear the stigma concerns and bicultural communities as well. And this is an ecosystem that gives us real-time understanding of what is happening in the community. So what I'm about to share is a snapshot or data that we're gathering still. Many organizations like ours conduct comprehensive regional needs assessment every 2 to 4 years. And this time we are collecting our needs assessment to gather input from older adults, caregivers, providers across the 10 region of counties that we serve. And like I mentioned before, we're still gathering data, but so far we have a little bit over 500 entries that we have been gathering in the communities, and 86.43% of the respondents identify mental health as a critical community need. And the top critical concerns were depression, anxiety, memory concerns, caregiver burnout and stress, sleep disruption, substance misuse, and limited access to service. And this level of consistency across respondents groups signal that it's not only a service gap, but it's also a research opportunity. These findings help to validate problem statements and identify target population and prioritizing intervention groups designs. So now, how aging networks serve as a strategic infrastructure for researchers. So aging network provides validated community-identified priorities, recruitment pathways that are built on trust, real-world implementation contents, and bilingual engaging capacities and cross-sector partnerships alignments. I often like to say that older adults and caregivers are greater influencers, and when you're trying to target that population, it is often deeply built on trust. So when research partners with community organizations, the results are way more productive. Next slide, please. So when researchers collaborate with aging networks in early proposal development phases, they gain insights into feasible translational realities such as caregiver time constraints, cultural stigma, digital literacy barriers, which influence the study design and implementation. This also includes the community infrastructure, the beginning strengths competitiveness of the research, and it also improves the recruitment and retention. It enhances equity, and it increases the likelihood of an intervention to be sustained beyond the grant period. Another great way to see is that you can also network directly with the grantors, which give you that funding within the aging network. When academia, government agencies, nonprofits, private partners, and community members engage together through the team science model, research becomes more publishable and it becomes more implementable. Aging networks are positioned in the transition to be that translational bridge. So I will also like to ask for your help to improve our services by sharing your voice as an older adult, a service provider, or a caregiver. We have, again, our needs assessment that we're still collecting until the end of the month, and we hope to share those findings with you. In addition, if you want to be part of the aging network that is regional here in the capital area, I invite you to join the Aging Services Council. You get a wealth of relationships, informations, and opportunities to share information and learn from partners as well. And in addition, we do have a grant to increase local dementia support, and our coordinator is in partnership with the Alzheimer's Association doing a virtual coalition for people who are interested in Alzheimer's and dementia-related diseases. So we do have also that interest form. I believe they're planning to meet at the end of March, so you still have time to be part of that first meeting. And that's pretty much all I have for you guys today. Thank you so much.
Thank you, Alita, for sharing your perspectives and those experiences with us. It's a perfect moment to pass the conversation over to Dr. Villagran, who is the director of the Translational Health Research Center at Texas State University. She's going to talk a little bit about THRC's collaborative approach to community-centered research partnerships. So with that, I will hand the conversation over to Melinda. Thank you.
Thank you. I want to thank all of you for joining us today. One of the things about Texas State University's research program is that we have a commitment to not only doing good science, but making sure that scientific breakthroughs are achieved in connection and collaboration with people that are working in the communities served by our research. And our partnerships are not something that are an afterthought. We don't disconnect our research mission with our goal to improve health in communities and make sure people live safer and happier lives because they have access to the healthcare that they need. I really appreciated Dr. Abert joining us today because we've heard that the structure of CPRIT, which has been tremendously successful and has really solidified Texas as the place where the best cancer researchers in the world want to be, and where we as Texans and as people who might need healthcare if we have cancer can find answers to solve or overcome cancer whenever possible. The difference, I think, between CPRIT and what we might experience with the Dementia Prevention Research Institute of Texas is that we don't have an MD Anderson for dementia research. We don't host the world's greatest cancer research facility in Texas, because I don't think it actually exists. I think that there is tremendous opportunity to do DPRIT projects that really take the very best science and connect them with the communities and the people that can inform the questions that we ask, our approaches to methodology, and help us make sure that breakthroughs that come from DPRIT funding reach people across Texas, because that's the intention of the funding mechanism. And I believe it's really, really achievable with meetings like this. I sit in a lot of meetings with academics, and our academics will talk to each other about really amazing things that you never hear about in the clinic or the community. And then I go in the community and I listen to people talk about really important needs that could be addressed if they were connected with clinical goals. But that connection is never obvious. And so our Translational Health Research Center at Texas State takes a very broad approach to do that work, make those partnerships, and connect science, policy, community outcomes, healthcare, and all of the things that we need to have an ecosystem of health within our state. Our center has 5 areas generally where we do work. We involve Texas State University faculty, researchers, and partners with institutions, core facilities, state and local leaders, companies, nonprofits, healthcare providers, and facilities. And we do that in a way that's very entrepreneurial and with a mind toward innovation and discovery. So in summary, I just wanted to thank everyone for coming today, because what this meeting represents is an opportunity to do research and implement programs and create partnerships that will strengthen a network to make DPRIT as successful as CPRIT has been for the state of Texas. And I believe that is going to happen. Whenever it starts, I sort of see the lawsuit or the, delay as being, a little bit of a bonus in some ways, because we need to hit the ground running and we need to make sure that we've done the work to understand the science, to get the best people in the room, and to make the pipelines where we can take things that are identified in research into clinics and communities and homes to help people that are suffering with dementia and Alzheimer's and improve brain health and serve our aging community as well. So, I saw a previous slide which said, team science really matters. And we believe that, because, doing research in a vacuum and then putting it in an academic journal behind a paywall doesn't do anybody any good. That is a critical step in the scientific process. But the other step is to make sure that you have interdisciplinary partners to understand not just illness, but also wellness, to understand the quality of life and the livelihood and the realities that people face as they age, and helping us figure out ways to maintain brain health so that we don't even have to deal with dementia or Alzheimer's in the future. Medications are one approach. Therapies, technology, devices, prevention is such a critical piece of this puzzle. And so we want to do community engaged, needs-based innovation in research and making sure that that research has the ability to reach people across the state once we have those tremendous breakthroughs from the great scientists that will be working on these issues for our state as a result of this opportunity that has come from the legislature and DPRIT. So I just, I'm very excited to see you all here today. I appreciate all the speakers, and I think we're ready to